and hopefully that will correct any issues. So thank you all for joining. Thank you for spending the next half hour with me. Going to advance my screen here. So we are meeting today to talk about the importance of breast density, to talk about how important it is to recognize breast density for our patients, talk about how it became such a hot topic. We'll talk about breast density assessment methods, and then most importantly, discuss how to communicate and educate our patients when they're told that they have an increased breast density and what supplemental screening will mean for them. Breast density is typically determined by the mammogram. It reflects the attenuation of the stroma and epithelial tissue, in other words, the fibroglandular tissue versus fat, typically defined as a ratio of fibroglandular tissue volume to the total breast volume. Now, a woman with a higher amount of fibroglandular tissue compared to fat means that she has dense breasts or high breast density. And a woman with a lower amount of fibroglandular tissue has a fatty breast or a lower breast density. So breast density is unique for each woman, and approximately up to 50% of women aged 40 to 74 in the United States have dense breasts. So we'll talk about what that means. The radiologist reports on 4 breast density categories using the BI-RADS reporting system that was developed by the American College of Radiology. We're going to talk about the BI-RADS 4th edition and what it offered and the changes that were made to the current BI-RADS 5th edition. With the BI-RADS 4th edition, it was primarily an area-based assessment, and this is what we're most familiar with, where a radiologist, when looking at the third MLO here, would say, yes, there is about 50 to 75% fibroglandular tissue here, so I'm going to call this a BI-RADS 3. When transitioning over to the 5th edition, it was more focused on the masking risk and mammographic sensitivity. And it really didn't address the risk for developing breast cancer. But that was the reason for primarily switching over to the 5th edition. And then they went to A, B, C, and D to minimize some of the confusion with BI-RADS 1, 2, 3, and 4 reporting of the result of the mammogram. So when looking at the population, this is what we typically see divided into 4 categories, where 40% of the population will have scattered tissue, 40 will have heterogeneously dense, and will be bracketed by 10% having fatty and the other 10% having extremely dense breasts. Breast density does, the distribution of breast density does vary geographically. And we see the typical is that 40 in the middle with scattered and heterogeneous and 10 fatty and 10% dense. But sites really need to be aware of the patients that they're servicing. In other words, site 1, the gray site here, has a higher percentage of dense breasts. And that's important to know so that you can serve that population better with supplemental screening. Often the categories are reduced to just 2 groups, where fatty and scattered is bucketed in the fatty category, and heterogeneous and extremely dense is bucketed in the dense category. And this is common, but is it the right thing to do for the patient? We'll talk about that. Breast density does fluctuate with the menstrual cycle. Estrogen plays a huge role, and when going through menopause and the lack of estrogen, we're going to see a decrease in density with the rate slowing at older age. And once you get over 65, there's typically little or no density changes. So factors associated with higher breast density is going to be younger age, lower BMI, hormone replacement therapy, birth control use, and factors associated with lower breast densities will be increasing age, higher BMI, having children, the earlier the age at first birth, tamoxifen use, which is a medicine that blocks estrogen, as well as physiological changes such as weight gain or loss. We'll start to talk about the importance of breast density. Well, why is it important? Breast density is strongly associated with the risk of developing breast cancer and masking risk, and several research studies have reported on this, where we see here a nice illustration of as the breast density increases, so does that cancer risk, and we see that sensitivity decreases as breast density increases. Breast density is an independent risk factor for developing breast cancer. In an extremely dense breast, a BI-RADS D category, where the risk is 2 times greater than the risk for the average woman, and 6 times more likely than women with fatty breasts. And in the lower breast densities, the BI-RADS category A, the lower of developing breast cancer is compared to the risk of the average woman. So very important as far as developing breast cancer. Also masking risk. This is where the dense tissue can mask or hide a cancer or make findings more subtle. And this is a really nice example where we see that star very easily in that fatty breast. That white star shows up nicely along the darker background, and how it tends to diminish or just blend in as that breast tissue increases. So when we're talking mammography, fat is our friend. The sensitivity of mammography to detect a breast cancer decreases in denser breast, and Destunis and Kerlikowski reported beautifully on this. You see the sensitivity decreasing as you go through the A, B, C, and D density categories. And this is a nice schematic of Destunis's work, how as the volumetric breast density increased, that sensitivity drastically decreased. A case here where a patient comes in, 48-year-old presents with bilateral lumps for a diagnostic mammogram. So what is going on here? Does she have fibrocystic changes? Well, we're going to figure this out. She did have a 3D mammogram performed with a synthesized 2D, and this is what you see here, the synthesized images. The mammogram shows no abnormality. She goes on to ultrasound as part of her evaluation, and 2 irregular hypoechoic regions were found, 1 at 9 and 1 at 10. And additionally, they noticed some lymph nodes in the axilla. Biopsy revealed that there was multifocal invasive ductal carcinoma with mets to the axillary node. So this is a very sad example of the masking risk when we have a dense breast. Breast density has become a hot topic over the years, and it started with one woman, Dr. Nancy Capello, when she was diagnosed in 2004 with stage 3 breast cancer right after a normal mammogram. And she did ask them, why didn't it find the cancer? And they told her that she had dense breasts and that mammograms are limited in detecting cancer in dense breasts. And then she further asked, why wasn't she informed? And they said it's not standard protocol to tell a woman her breast density. So in 2009, Connecticut, her state, became the first state in the United States to legislate breast density notification. So they mandated reporting breast density on every mammogram. So every radiology office that provided mammography services had to do this. And it came along with insurance coverage for whole breast ultrasound as an adjunct to mammography. Now, a lot has happened since then. A lot of states have followed suit But every state is different, and not every state offers this insurance coverage for adjunct imaging. So there's still a long way to go. But this grassroots effort was monumental. In last year, so changes were made to the MQSA, and it requires that reporting of dense breast tissue to the patient, where a single national density reporting standard is being worked on, and it shall be adopted by all. And this is expected out later this year. And they report that there shouldn't be a delay expected with this due to COVID, which, you know, it's nice that there's not going to be one thing that's delayed anyways. So we'll talk about breast density assessment and dive deeper into the methods and challenges around that. Knowing a woman's breast density is very important for risk determination as well as supplemental screening. We do need it to be objective and consistent. This is essential. It's essential for each patient across a population and for year over year. So there's a couple of ways. Visual assessment will be subjective and variable, and typically area-based, and we'll talk what we mean by pseudo-volumetric. And automated software, which will provide objective, consistent assessment of breast density, and there's a couple of ways, area-based or volumetric. Visual assessment is subjective due to inter and intra-reader variability, mammography system variability, and then the subjective nature when evaluating volume. And we'll touch upon these. So inter-reader variability is going to be variation among readers, where some radiologists might say this is a B, and some might call it a C. And when we talk about intra-reader variability, it means that there's variation from one observer, where one day the doctor will call this a B, and then next week the same doctor will call this a C. Mammography system variability can get in the way. Here we have a nice example of the same patient imaged over 6 years, and you can see the visual appearance of density varies from unit to unit, GE, Hologic, and Siemens. So the key is to remove the system variability, and that is done by assessing the raw images, and we see that they're very similar irrespective of the vendor. Volpara Density is an automated software that uses raw data, raw images to assess breast density. We'll talk about area-based versus volumetric density. The first schematic here, we see that the breast is compressed. We see absolutely nothing interrupting that X-ray beam, and we would all agree that there's 0% fibroglandular density here. The middle schematic shows us a tiny little island of glandular tissue, and when compressed, it looks like it's about half of the breast. The third schematic shows us another two islands of fibroglandular tissue, and when compressed, still looks like it's about half of the breast, although it's a little bit whiter. But when you look at this volumetrically, the middle schematic here, we see that this is a very small amount in comparison to the total volume of tissue here, where it would be about 12% fibroglandular tissue. And the third schematic would be double that at 24%. So this takes into consideration the volumetric density, and the concept of a weighted average will inherently capture the increased masking risk. Now, the radiologist is not going to look at the middle and third schematic and say they're the same. The radiologist will look at this and, you know, maybe bump it up a little bit because of the whiteness of the tissue seen. And this is what we talk about when we refer to pseudo-volumetric. The BI-RADS 5th edition, as I said earlier, focuses mainly on masking risk and sensitivity, does not characterize density for the risk of developing breast cancer. But what is commonly accepted and proven is that there is an association of breast density with the risk for developing breast cancer, and that density is an independent risk factor. And this is a quote from the NIH. Women with dense breasts have an increased risk proportionate to the degree of density. Therefore, density assessment should be personalized, such that risk assessment is personalized. And the 4 categories that are used do not attend to that personal density assessment or risk. So we need to provide a continuous scale that better reflects density as well as the risk for developing breast cancer. And automated software does that, provides that volumetric assessment on a continuous scale that closely aligns with the risk of developing breast cancer. And we'll talk about that. This is a nice example of a Volpara density scorecard that right off the get-go tells the doctor this is a D, extremely dense for that masking risk. But we also provide a volumetric breast density on that continuous scale, and you can see where she is on that scale in the density categories. This volumetric breast density percent can also be brought into a risk assessment tool, Tyrer-Cuzick 8, that will provide a risk score for that patient. And we'll dive deeper there in just a moment. So TC8 is the only risk model that brings breast density into the evaluation. There's an area here, a field here, where you can actually put in the volumetric breast density percent or the BI-RADS letter grade. This VAS percent density is primarily used for research. Let's dive deeper here. We see 2 patients here with the same risk characteristics, both 55, went through menopause at 52, had a mom with breast cancer at 60, and they both fall into that BI-RADS C spectrum, but they have very different density appearances and potentially different risk assessments, where one is a lower C at 9.1% volumetric breast density percent, and the other woman has a high volumetric breast density percent at 14.9. We'll talk about how we can use Tyrer-Cuzick 8 to give a more precise risk assessment for that patient. And we're going to look at the patient with that high C, the volumetric breast density percent of 14.9. So looking at her and putting her, the letter grade, that BI-RADS C in, her lifetime risk would come out at 16.8. But when putting the volumetric breast density percent of 14.9 in, now it gives that more personalized risk assessment for her, where her lifetime risk is now 22.6, above that 20% where she's now eligible for screening MRI. So it really does give that patient a more personalized risk when using, bringing the density into TC8. We have all of this information. How are we going to communicate and educate our patients if they are in the higher breast density categories? There are several resources out there that I just listed a couple here, Dense Breast Info, and the ACR will provide resources, brochures that you can download, and you can put your site's logo in and provide this information for patients. This is a great resource for patients as well as sites, health professionals. Who's going to have that conversation with the patient? There's been a lot of debate over this. Should it be the radiologist? For me, that's kind of a no-brainer, but is that really practical? The radiologist, time is valuable, as well as that's an expensive resource, so to speak. If it's the referring physician, is that person the right person? Are they equipped with the knowledge to communicate what breast density means for that patient? In some cases, it's a nurse navigator, but there's definitely an emerging role for the technologist to convey that information, as well as triage that woman for supplemental screening. And who knows what this is going to look like as sites reopen from COVID. We're talking about the screening paradigm, so to speak, the supplemental screening paradigm. DBT is being widely adopted and very common in centers now, and this has improved mammographic accuracy, so that's wonderful. Whole breast ultrasound, whether it's automated or handheld, finds additional cancer, so should be available to women with dense breasts. MRI has the highest sensitivity for women at high risk. Molecular breast imaging and contrast enhanced spectral mammography has similar sensitivities to MRI. So there are tools out there that we can offer as far as supplemental imaging for patients. And in summary, knowing a woman's breast density, accurately identifying that density for a patient is very important so that we know the masking risk, we know the increased cancer risk. Knowing that information is one thing. We have to properly communicate that and educate our patients so we can get the right people to supplemental screening, so we can have improved breast cancer detection, and that will result in decreased mortality, which is what our goal of screening is. So thank you so very much. For additional information, please reach out to our support at support@volparasolutions.com, as well as the clinical specialist team listed here. Please remember to access the survey link that we're going to post in the chat. This will ensure that we get your certificate out to you, and hopefully we have a little bit of time for questions.
Thank you, Renee. That was fantastic. Did a great job. I did just post the, oh, hang on, I'm getting a lot of feedback. So I'm going to go ahead and mute everybody for a second. Okay, I did post the link for the evaluation and the survey for you to fill out. There's a little link there. This will allow us to know that you did attend this session, and we get your full name and information. Some of you signed in with just maybe your first name or your initials, but this will tell us that you were here. We can get those certificates out to you in the next couple of days. Does anybody have any questions for Renee while she's got another minute or two here? So we're getting some thank yous, and that was great. Excellent. Please feel free to unmute yourself by clicking on your little microphone. If anyone wants to ask a question, I'll be quiet for a second. Oh, come on. Boy, Renee, you might get let off the hook easily.
Renee, are you seeing an escalation in the interest or in density by the patients? Are you noting that patients are coming in asking about density more now than before?
Great question, Pat. In my last life, I was in my life before Volpara, I was a patient advocate, and how we approached that is new patients. We brought it up to them immediately. We would sit and have like a little conversation about what to expect during their visit, and introduce breast density then. And it really opened up a lot of questions that patients were allowed to ask at that point, and then provided some information for them. And then if they were identified as having increased density, we would take it from there. But knowledge is power. I say that for technologists out there and patients alike. Knowing is the key to get to the right tests for that individual.
Okay, so at the point of the communication with the patient is where the value comes in the technologist understanding, having a general understanding of density. You know, that in the end they can have a conversation based on facts and data.
Exactly, exactly.
Okay.
And you want and always want to be prepared for those questions. So knowing more than what your patient will ask is also key.
All right, thank you.
And just one
Any
other
other
quick
que-
reminder. Oh, sorry about that, Renee. I didn't mean to speak over you. I just wanted to let everybody know that we're going to try to do a couple more of these in future Thursdays. Look for another invitation coming out tomorrow for next Thursday. And then the following Thursday, we're going to be doing some compression and positioning sessions as well. So please feel free to join us in those upcoming sessions. Got 1 more minute left before we hit the top of the hour. Does anybody have any other questions? Okay. Well, I keep posting the link in the chat for you to fill out the evaluation. Remember, that's how you're going to get your CE credit, is by completing that evaluation survey. I'm going to put it up there one more time so that you all see it. So just make sure you click on that. You can always email support@volparasolutions.com if you need that link or that information. But again, I'm going to thank everybody so much for joining today. We really appreciate it. And thank you, Renee, for your time, your expertise. And I just want to wish everybody well. I know it's a very difficult time, and I know we have a lot of people struggling, and we just want to say that we wish you the very best. And if we can help in any way, please feel free to reach out to us. So thanks again, everybody, and have a great day.